It's a pleasure to welcome you to the VEITHsymposium. It's great to be back in New York. It's great to see so many attending and so many industry partners who have been here at the VEITHsymposium. Dr. Veith read a paper that several of us who are going to be talking today wrote in the Journal of Vascular Surgery as authors. The paper has to do with the practice guidelines for intermittent claudication, and the fact that when looking at VQI participants with a huge number of patients, over 10,000 patients, that many of us do not adhere to the SVS practice guidelines and standards which have been established for the interventional treatment, that is the non-surgical endovascular treatment of intermittent claudication. So the questions are going to go to three of our participants, and the first to Adam Beck. Dr. Beck is a professor of surgery and chief of vascular surgery at the University of Alabama. He was an author on the paper and also has represented the SVS in international societies that do with practice guidelines. And I'm asking him to discuss this particular paper where he was an author and the fact that this is patient-reported outcomes. And in fact, they did not report on ankle brachial index, physiologic studies, including treadmill testing, nor patency after the procedure, and whether or not those are factors that should be in a paper that looks at outcomes from procedures for intermittent claudications. Adam?
Ideally, we would have physiologic studies like a treadmill study. Unfortunately, in the VQI, we don't have this, so this is a limitation of registry data. We definitely should have evidence of patency after the procedure, and we really shouldn't be treating a duplex arteriogram or a contrasted arteriogram. We should be treating the patient if there's any question of whether the patient actually has claudication. If they have symptoms that might be consistent with pseudoclaudication, they should have a treadmill study.
Thanks, Adam. Our next question is going to go to Mike Conte. Dr. Conte is the Chief of Vascular and Endovascular Surgery at UCSF, but equally important, he was the first author on intermittent claudication practice guidelines, which I believe are published in 2014 or 2015. Tell us about the original practice guidelines, whether they're still relevant, and whether and how we should think about this paper, which showed that only about a third of the patients even met the guidelines, which were published in 2015. Mike?
Yeah, thanks, Peter. As you know, when any of the societies, including the SVS, sits down to think about a practice guideline, the first thing that we do is we launch a scientific review. And we review the state of the current evidence, which we did thoroughly back in 2015. Unfortunately, the state of the evidence in claudication is still limited. We don't have a lot of randomized controlled trials with level 1 evidence, particularly comparing different treatment strategies. We have trials comparing specific devices against other devices, but not really treatment strategies. So that's a limitation that we still have. However, in the last, certainly in the time that's passed since then, there's been an evolution of certainly pharmacotherapy and also more data around different types of treatment strategies. We are right now in the process of doing a targeted guideline update for the SVS and the claudication realm. That's in process.
Thanks, Mike. Next question goes to Karen Wu, and Karen is a colleague at UCLA, but more importantly, she's developed really an international reputation for her expertise in outcomes, large databases, and particularly in not only practice guidelines, but appropriate use criteria. So I'd like to ask Karen to tell us the difference between practice guidelines, appropriate use criteria, and how the appropriate use criteria that she recently was involved in publishing, how that differs from the practice guidelines that he developed and the paper that John Bath, who is the author of this paper that we're discussing now. What's the difference between the two?
Thanks, Dr. Lawrence. That's a great question. It's a question that gets asked all the time. And I'll start with guidelines. So guidelines typically tell us what to do or how to treat a certain aspect of a problem. So for example, it tells us, what kind of imaging we should use to evaluate a patient. What is the most useful kind of imaging, what is indicated, or it tells us, for a patient with a certain kind of problem, like, for example, something we're probably most familiar with is infrarenal aneurysms. It tells us, the size criteria for repair of an infrarenal aneurysm. So it tells us how to manage, sort of one thing at a time. What appropriate use criteria does is it can tell us what the best treatment is for a patient with a given set of characteristics. So in the example of the appropriate use criteria for intermittent claudication, we incorporated things including smoking status, how far the patient can walk, what the patient's frailty or functional status is, and all the different permutations of those characteristics. And so it was totaled of almost 3,000 different permutations of patient characteristics. And you can see for each of those permutations what our panelists recommend is the most beneficial treatment for that patient. And so it really helps clinicians to drill down to specific characteristics and how they should treat a specific patient.
Now we'll go to the second round, and first Dr. Conte, ask him about the criterion that were in the 2015 paper. As I remember it, the goal should be that there should be a less than 50% likelihood of recurrence at 2 years. And my question is, first of all, how did he come up with that number, those goals, and are those goals still relevant today? And are there exceptions to that situation? Could you think of a scenario or a case where you might, I'm going to use an example, a professional golfer who might not meet the criterion but is willing to take the chance? Since there were so few amputations in the paper that we published, is it worth informing patients and allowing them to take the chance, even if the outcomes are very poor?
Thanks, Peter. It's a complex question. So first and foremost, claudication is a chronic condition that leads to disability, but it's not limb-threatening. And so when we think about invasive procedures to treat claudication, the group felt that importantly, they need to be safe, and they need to produce some kind of durable benefit. Many of the trials that are being done, for example, of devices, use very short time frames, such as 1 year. This may be reasonable for someone with limb threat, but it seems inadequate for a chronic, long-standing, non-limb threatening condition. So, in essence, what the guideline group wanted to do was go out and establish what's a reasonable threshold, what's a minimum threshold for an effective treatment. And truthfully, we didn't have data really to base that on. The best data that we could get would be to actually involve patients, would be to recruit patients into the guideline process, do a stakeholder survey of what their feelings are about the trade-offs between an invasive procedure and how long should it last. The other thing to add about that is that, as Karen sort of alluded to, the number of scenarios is very, very complex. So it's not going to be necessarily one answer, but we thought it was important to establish a baseline threshold. For example, if you have a patient who has the same problem in 2 legs, with the same anatomy in 2 legs, and it has a 60% of chance of working at 1 year in 1 leg, 60 times 60 is under 40%. So you have to do this, you have to encourage that kind of thinking process for informed decision making in the patients. So in the future, I think the best way to do this experiment, if you will, is to involve patients in the conversation.
And Mike, that professional golfer who has claudication and tibial disease, is there any circumstance where you would consider, since they may not lose their limb, doing that procedure?
Before we get to the golfer, let me go back to the first thing I stressed, which was safety. And claudication, first of all, the risk of limb loss is low, and the treatment risk of early amputation or mortality is also extremely low. So you're not going to be seeing terrible early complications or safety events. However, the potential risk of accelerating the disease process over time is harder to measure. If you start treating patients early and they get intervention after intervention, there's a pretty real risk that you're driving the disease to be more diffuse, more distal, and more severe. Some of these may not get amputations, but they may actually worsen over time. They may get rest pain. They may slowly or more rapidly go towards chronic limb-threatening ischemia. So there's a safety concern, and then there's a benefit question. There really is no data that says that intervening for tibial arteries improves the outcomes of patients with claudication. Could there be unique circumstances? Sure. If a patient has a very isolated focal lesion in the tibioperoneal trunk and that's the whole runoff to the leg, I could imagine that that could come up. The problem is that those are rare circumstances, and I would probably counsel my golfer to just keep using the treadmill.
Okay, and hopefully the person who was asked that question wouldn't have done 100 tibial interventions in the past year, because your profile is also very important. I'll ask Dr. Wu now, in both this paper and also the appropriate use criteria, AUCs, that she was just involved with, they stress the importance of smoking cessation, exercise, and risk factor modification. And so the question is, for claudicators, what do you do if a patient either hasn't done them or they haven't been initiated? Should we still consider interventional treatment, or should that be sort of a mandatory first step?
So Dr. Lawrence is alluding to the finding in this manuscript that about 45% of the patients who were treated for claudication in the VQI were active smokers. We were very surprised to find that. And I will say that in the AUC development process, our panelists, which consisted of vascular surgeons and cardiologists and interventional radiologists, all felt very, very strongly that smoking cessation was a prerequisite for an invasive intervention for the treatment of claudication. In very few circumstances where the patient perhaps has a severe lifestyle limitation and or a very short walking distance, the panelists rated that as maybe appropriate and in some cases appropriate. But that also brings us to the question, what does appropriate use criteria mandate? There's been a lot of, I think, uproar about that. And, appropriate use criteria doesn't tie a clinician's hands to a certain way of practicing. Ultimately, as we pointed out in the criteria, the write-up of the criteria, is that ultimately what needs to happen is for informed shared decision-making to occur between the clinician and the patient. And that presumes that the information that is presented to the patient includes a risk of amputation. In my own practice, I've found that when I tell patients, there's no risk that you're going to lose your leg from this. There's a very good chance that you get better if you walk more. But there is a very, very small chance that if you do have an invasive intervention, you could at some point have an amputation as a complication. Most patients will say, I will walk, I will quit smoking. So I think it's very important for shared, honest decision-making to occur and for the clinician to present an unbiased, honest assessment of what the likelihood is of the outcome.
Great response, and I would say that for any of you who have not read Atul Gawande's book, Better, that as clinicians we can do better, and the response of informing patients of all the things that they can do before intervention, I think is our responsibility as vascular specialists. Last question for Adam is, you are very involved internationally as well as in the United States, representing the SVS on, you might tell them what your role is in some of the international databases. And I would ask you about, are there international claudication guidelines, and are guidelines in agreement? And if they aren't, how do you handle where you have 3 or 4 guidelines on the same topic and they may come to different conclusions?
I've had the pleasure of representing the SVS and the VQI in something called the International Consortium of Vascular Registries. In fact, we're in the middle of our biannual meeting right now today. The European SVS guidelines for claudication are buried in a Ph.D. document, but if you look at those and compare them directly to our SVS guidelines, they're very similar. They cover all the things that have been alluded to already: medical management, walking regimen, risk factor modification, smoking cessation, all those things. So they're in agreement for claudication. And if I can just editorialize for a moment and say something about what Karen said a moment ago, it's a lot easier to say to a patient, "I will fix you," than it is to spend 30 minutes describing to them how they need to quit smoking, how they need to walk more. It takes a lot longer to do that. And it's much easier to say, "I've got a procedure, it will fix you." And and I think that it's important to make them understand that their leg's not at risk. As a general rule, their leg's not at risk, and you really can impact their health overall much more by getting them to do these things and get them on the right medications and getting them to quit smoking. So, and I think they do a very good job of this in Europe, and maybe a little better job than we do in the United States for patients with mild to moderate disease.
One last one to follow up. So with Dr. Conte, let's go back to the patient with tibial disease, because I think, as I understand it, there are certain practice guidelines by certain specialties. I think there are SCAI guidelines that may say that tibial interventions of 1 or 2 vessels for claudication is appropriate. And I believe that your guidelines say that they're not appropriate. How do you handle when one specialty says one and one specialty says another? And then a few years ago, I was on the MedCAC committee, which is for CMS. And one of the points that they always made to us is you got to get your acts together. When you have guidelines that say different things, how can CMS say that one has to be used? So it's up to the guidelines to be in agreement. What do you do when specialties don't agree? How do you handle that?
I was just using this analogy downstairs. Let me first worry about the house of vascular surgery, which is also pretty diffuse. First of all, I think we do know that revascularization can help people with claudication. That's for sure. It's really about, the guidelines are really trying to help people pick the right patient for the right thing at the right time. And there's 2 philosophies around guidelines, or there's a mixture, I would say. Should it be driven totally by evidence, or how much should it be influenced by what's actually happening in practice in the real world? And I mentioned that we don't have enough level 1 evidence comparing in a definitive scientific way the benefit of these procedures and how they impact patients' walking performance and quality of life. So the big message, I think, is we need some trials, some large-scale trials of patients undergoing these interventions where we can actually capture who benefits and who doesn't, who's a good responder and who's not. But I would also say that in the absence of that, it's not free lunch. Just because the procedural risk is low, there should still be some evidence to support intervening on a patient with a certain pattern of anatomy. Not to go too far, but we know that claudication pain occurs in the large muscle groups, which are largely fed by the larger arteries above the knee. I mean, we're standing on the shoulders of giants with that. That's not brand new news. There could be situations where the tibial disease contributes, but I think the problem is that by making something seem like it's possibly appropriate, what we're seeing actually now from recent papers from Caitlin Hicks is about 1/3 of the patients getting claudication intervention in Medicare are getting a tibial intervention. And about 1/3 of those are getting more than one tibial artery intervened on with no evidence to support it. So that's not rarely, that's commonly being done. And I think there needs to be evidence to support a practice that's that diffuse.
So most of you know that the best guidelines were recently reported and now published. And I hope that someone who's listening to this will either contact Dr. Conte or he'll decide to put together, now that BEST has completed a claudication trial, which would take a few years, but that all of you who are listening to this will come to the VEITHsymposium in 2, 3, 5 years and hear about a prospective randomized trial which addresses the many issues that we've discussed today related to intermittent claudication.